Welcome. Okay, today we are going to take a super dense, kind overwhelming chapter on mobility and immobility, and we're going to boil it down into a high-yield study guide. This is everything you need to know to ace your exams, and more importantly, to be confident in your clinical practice.
So here's our game plan. We're going to build this from the ground up, starting with the basic definitions. Then we'll get into the really interesting part, the body-wide effects. After that, it's all about you, your nursing actions, the gear you'll use, and how to spot an emergency. And we'll wrap it all up by putting your clinical judgment to the test. All right, let's dive right in. Before we can even begin to talk about fixing the problems caused by immobility, we've got to have a rock-solid understanding of what we're actually talking about. So, mobility. It's so much more than just walking, right? It's about freedom. It's about purpose. Think about it. It's being able to get up and grab a glass of water when you're thirsty. That simple act requires your nervous system and your musculoskeletal system to be in perfect sync. Immobility, then, is when that freedom is taken away. And this next part is the single most important principle we're going to talk about today. The longer a person is immobile, and the more profound that immobility is, the higher the risk for a whole cascade of really serious complications.
Now this is where it gets really fascinating and kind of scary. Immobility isn't just one problem. It's like tipping over the first domino in a huge, complex line. One system starts to decline, and it triggers a chain reaction that can impact a patient from head to toe.
It all starts with the parts of the body that are literally just lying there. Your skin is under constant pressure, which squeezes the tiny blood vessels and can lead to nasty pressure injuries. At the same time, deep inside the lungs, gravity is causing fluid and secretions to just sit there, creating this perfect swampy environment for pneumonia to grow. The cardiovascular system takes a massive hit. You know how your calf muscles act like a second heart, squeezing blood back up to your chest when you walk? Well, when you're not walking, that blood just pools in your legs. This is a setup for dangerous blood clots, or DVTs. At the same time, the body's metabolism slams on the brakes, starts breaking down its own muscle for fuel, and even pulls calcium right out of the bones. And the dominoes just keep falling. Muscles waste away, a process we call atrophy. Bones get weaker. Joints can lock up into painful contractures. But it's not just physical. Think about the mental toll. Being stuck, isolated, losing your independence. It's a direct path to depression, anxiety, and even confusion. Okay, so we've seen the damage. It's pretty grim. But the good news is we can fight back. This is our playbook. This is what proactive nurses do to stop that domino effect in its tracks. When it comes to the skin, you've got to become a detective. You're constantly scanning for any subtle sign of trouble, a little redness, a change in temperature, and you're relentless with your interventions. Turning every 1 to 2 hours isn't just a task to check off. It is the #1 way to prevent pressure injuries. For the lungs, we are all about being proactive. That turn, cough, deep breathe routine might sound simple, but it is a literal lifesaver. You're coaching your patient, encouraging them to use that incentive spirometer like it's their job, because it is. You are their personal trainer for their lungs. Now, for the cardiovascular system, pay close attention because there's a huge NCLEX pearl right here. We teach patients to avoid crossing their legs or putting pillows right under their knees. Why? Because it can literally kink the veins like a garden hose and block blood flow. And never, ever massage a warm, tender calf. If there's a clot in there, you could break it loose. So, we know what to do. Now let's talk about the gear we use to get it done. These are the tools that help us promote mobility and prevent all those nasty complications. Heat versus cold. It's really simple when you think about it. Heat opens the floodgates. It increases blood flow to an area, perfect for relaxing a stiff muscle. Cold does the exact opposite. It constricts those vessels, reducing inflammation and swelling.
Okay, the cane. So many people get this wrong, but there's a great little memory trick. C-O-L, cole. Cane, opposite, affected leg. So you hold the cane on the strong side. It moves forward with the weak leg, like they're partners. Then the strong leg follows. It creates a nice, stable base of support. Crutch safety is absolutely critical. And if you remember just one thing from this slide, let it be this. The weight goes on the hands, not in the armpits. You can cause serious, permanent nerve damage by leaning on the top of the crutches. It's all about pushing down through those hand grips. All right, we need to switch gears now. We're heading into code red territory. This is when things get serious fast. These are the life-threatening complications that you have to recognize instantly and respond to without hesitation.
So let's be crystal clear about the connection here. A DVT is a clot in the leg. A pulmonary embolism, or PE, is what happens when a piece of that clot breaks off, travels through the bloodstream, and gets stuck in the lungs. A PE is a DVT that has decided to go on a road trip with deadly consequences.
The key difference to spot here is local versus systemic. A DVT is a local problem. One leg is swollen, red, and warm. A PE is a full-blown systemic crisis. And the word you have to burn into your brain is sudden. Sudden shortness of breath in an immobile patient should set off every alarm bell in your head.
Okay, picture this. You walk into the room, and that's what you see. Panic in your patient's eyes. They're struggling for every breath. Your brain has to instantly filter through all the possibilities and land on the most likely culprit, a pulmonary embolism. So what's your move? What is the very first thing you do? Your first two moves, without a doubt, are to sit the patient straight up and apply oxygen. High Fowler's position literally gives the lungs more room to work, and oxygen is, well, it's what they're desperately lacking. These two actions can be life-saving while you're calling for help and getting ready for the next wave of interventions, like anticoagulant.
All right, you have absorbed a ton of information. We've covered the concepts, the actions, and the emergencies. Now, let's put it all together. It's time for the final challenge. This right here is pure gold for your exams. The NCLEX loves to test your ability to prioritize. And for immobility, the pulmonary embolism is the ultimate bad guy because it attacks breathing and circulation at the exact same time. It will almost always be the #1 priority. So here it is. You've got two big problems staring you in the face. You have a brewing respiratory issue, probably some atelectasis, but you also have the classic signs of a DVT in their calf. You have to decide which one is the ticking time bomb, which problem poses the greatest, most immediate threat to your patient's life. That right there is clinical judgment.